Oops. So now we're going to order our second O. We're going to prioritize what do we do first. When I see a functional medicine patient in my clinic, that's somebody who's coming in to get fixed. They've been to 18 other doctors. They're tired. They've got chronic fatigue, fibromyalgia. They have pain. They're not sleeping. Their hormones are messed up. When I see those patients, I know it's not going to be a short visit. And I know that when I finish, I'm going to have a lot of information about what's going on with them, and I'm going to have a lot of ideas about how to fix them. So when I first started doing functional medicine, I'd do my matrix, and I would come up with my plan, and it would be like 15 things long, and I would tell them everything that was wrong with them and where it came from. And they would leave my office with their heads spinning around. My nurse would say, "It's okay, honey. We're going to sit down and talk about what Dr. Hayes said." And I finally learned that I really needed to do the order part. I needed to prioritize. I needed to start with usually something that would work, otherwise they're not coming back. And I needed to start with something that they wanted addressed. So I may want her gluten sensitivity addressed, but that's not what she wants. She wants to stop losing her hair. If I don't address that, she's not coming back. So what does she want? Well, she wants to get her energy back. Why does she want to get her energy back? So that she can keep doing all the things that got her here, that got her to this visit. She didn't get to this visit by taking brilliant, good care of herself. And what she was doing required a lot of energy, and so she ran out of energy, and now she wants her energy back. And if you give it back to her, what's she going to do? She's going to take that energy and go right out and keep doing everything wrong. She wants to lose weight, and she wants to keep from losing more hair. So I've got to address those three things. Okay, so what are my top priorities? Well, I want to address her nutritional deficiencies. And I want to look at her conversion of T4 to T3, and I want to try to stop the autoimmune attack on her thyroid. So her priorities are over here and mine are over here. How do we get them together? Well, here are some of the nutrients that I think she's going to need. Okay, so we've got to consider celiac, we've got to look at stress, selenium and zinc, vitamin A, exercise, this group of nutrients here. And this is actually good that there are some nutrients that I can give her. Particularly in America, if you can give a pill, they're happy. If you tell them they have to change their diet and lifestyle, they're not so happy. Okay, then we get to initiate, the I in our mnemonic. And this is the part where she and I have to come up with a plan that will actually work for her. So I know that I may give her a plan and she may go home and try to do it and not be successful. And I've got to be sure that if she is not successful, that she will come back and say, "I didn't get the right plan from you." And not come back and say, "I'm a failure. I couldn't do it." So I often tell my patients, if you can't do this plan that we've agreed on, it is not your fault. It's my fault I didn't come up with the right plan for you. And sometimes that will help people to go like, okay, she's going to take some of the responsibility. It's not going to be all about my failure. So what did Dan do with his patient here? Well, this is kind of interesting because a lot of people would have changed her thyroid medication, looked at reverse T3, put her on a strict elimination diet. Dan put her on selenium. Put her on selenium. He gave her a little bit of iodine. This is 150 micrograms is not a lot of iodine. It's just not 15 milligrams of iodine, which you sometimes see. In America, we don't eat a lot of seafood. And we eat almost no seaweed. And we have very low and falling levels of iodine. If you take an American and put them on high doses of iodine, the kind of iodine intake that many people who live on the coast in Asia normally eat, they will shut down their thyroid. So we give very small doses of iodine. He gave zinc, not a very high dose of zinc, kind of a normal dose, and vitamins A, E, D, B2, B3. That was on the list if you'll look at Dr. Hanaway's lecture. He left her on her current dose of levothyroxine. He told her to continue her other supplements. He didn't, and he asked her to consider a gluten-free dietary program and to be tested or to be tested for celiac disease, and she said, "No way are you taking away my bread." He didn't panic about that. He said, "Okay, we'll come back to that." So did we address her top 3 issues? Well, if he's right about his diagnosis, that it's a nutritional problem, we probably did address the thyroid, which might help her weight and her energy. Hair loss, she's going to have to look into her dietary patterns first. Did we go to places that were too uncomfortable for her? Yes, we did. We threatened her stash of bread. And did we give her a plan that she could accomplish? Did we do too much or take away too much? So I really like to start by adding things. People are very worried that you're going to take things away from them. They've struggled. They are hurting. They've lost a lot in their lives sometimes. And if you're going to take things away, that's too hard for them. So I often do what Dan did. I start by giving them things. Let's add vegetables to your diet. We won't take any bread away. We won't take your dairy away. But I just want you to add vegetables. Now, if she's successful adding the vegetables, what's going to happen? Lots of good things. Not the least of which is that she will crowd out some of that bread and some of that dairy and some of that fat and some of that sugar, and she'll be eating the nutrients that give her the minerals and vitamins that she needs. So did Dan ask, what do we need more of? What are the gets? What do we need to get more of? And what she needed to get more of was she needed to get more vegetables. She needed to get more sleep for her stress. She needed to learn more about how stress in her life was affecting her thyroid. Okay. And then, so she needed to get her critical nutrients, she needed to adjust her thyroid meds, and she needed to address her perimenopausal issues. And what did she need to get rid of? What are her RIDs? Well, she needed to get rid of reactive foods, which we haven't accomplished yet. She needs to address stress and get rid of some of her stress. And she probably needs to get rid of some environmental toxins. Jeffrey Bland used to say the thyroid is the sentinel gland for the environment. The sentinel gland for the environment. Meaning, it's one of the first things that responds to toxins in the environment by being damaged and not working properly. Okay, so now we're going to go to the T, which is to track. Now, I don't know how you track, but I can tell you that tracking people with multiple functional medicine problems can get quite complex. So you do your functional medicine history, and you know there are things to look at in communication, and you know there are things to look at in assimilation, and you know there are things to look at in energy. And you may not start treating all of those things at once, but at some point they're going to plateau, they're going to stop getting better, and you're going to have to go back and pick up some of the areas that you've left behind. So the way we do that in our clinic is with a form like this. So we've put assimilation, biotransformation, communication, the nodes of our functional medicine matrix. And then we have the visit and then the follow-up. So what supplements did we prescribe? What medications? What laboratory tests did we order? What dietary changes? Did we refer them to someone else? And then how did they do? Did they go have the referral? Did they take their medication? How did they do with the supplements? Did they make the dietary changes? And then based on how they're doing there, we make the next set of recommendations. And that way, we can follow the patient. In fact, two of us can exchange a patient and know exactly where we are in the tracking. If we have something here that says fatigue, but we didn't start addressing fatigue, we started by addressing communication, okay, which is here, her thyroid problem, we may go back at some point and say, there's mitochondrial dysfunction. There is not enough energy being produced. You're going to learn more about that tomorrow. And let's go back and look at what we can do to improve energy with that part of the functional medicine matrix. So what happened to this patient? Well, she came back 2 weeks later. That was good. It's good if your patient comes back. She felt warmer, especially her hands. She noticed that her energy level had picked up, her skin's not as dry, and her constipation has improved. She has noticed changes, none of which involve her weight loss, her hair falling out, her fatigue, but she's noticed changes. So now you can say, wow, that is great. You know what that means? That means your thyroid is working better. So what's the plan? Add more thyroid? Add more supplements? Do something different? No. Dan was very careful with this patient. He said, that's good. We're making progress. Keep doing what you're doing. And see me back in 2 weeks. So she came back in 2 weeks. Well, now she's more energetic. We're addressing one of her top complaints. Her hands and feet are warm. Her fatigue has improved. Now she's starting to see that this doctor knows what he's talking about. Okay, I'm feeling better. And look, all I did was take a handful of supplements and eat more vegetables. This is great. Okay? So what did Dan do? He just said, keep going. It's sometimes the best medicine to do the very least that gets a change to happen that the patient notices. Because the human body is completely connected. So you make a little adjustment over here, and this is going to change, and this is going to change, and this is going to change. They're all going to readjust, and that may be the best way to get the whole system back in balance. Sometimes if we make too big a change, we throw the system out of balance in another direction, right? So he said, "You're doing great. See me in 3 months." Well, now she feels really good. Her energy has been so improved. She's tolerating working in the air conditioning. She's not cold all the time. And guess what? Her hair's not falling out. By the way, if hair falling out was the issue, I would have warned her that it would take 3 months for her to notice, because hair follicles fall behind what's happening in the body. If you start losing hair, you started losing the hair 3 months ago. If you start gaining hair back, it's going to take 3 months of the right kind of nutrients to grow hair before you're going to see a change. So she's seeing an immediate change. Her concentration has improved, and she doesn't seem to have as much memory problem. She feels more even in terms of her emotions and her ability to concentrate. Her body temperature has increased, and she's not having as much trouble with sleep. That means her adrenals will get better. If she can sleep, she will heal her adrenals. If you can't sleep, you are not going to fix your adrenals. Her stools are regular. She's not constipated. Her skin is no longer dry, but she's continuing to have hot flashes. Okay? So that may be the next thing that she'll want addressed. And look what's happened to her thyroid numbers. Her TSH has dropped down. It's not quite into the ideal range. We like to have patients who are on thyroid medication have a TSH between 1 and 2. Her free T4 has actually gone up a little. We'll have to watch that because she may get so healthy that she doesn't need as much thyroid. Her free T3 is now well into the normal range. She is converting T4 to T3. And interestingly, her antibodies have actually dropped. Probably because there's not as much damage to her thyroid, ongoing damage. What's the plan? Keep going. Okay, so how are we communicating? Are you understanding? Is the translation able to keep up? Yeah? Okay, good. Well, let's do one more case. I think we have time. So back to G. G stands for gather. Okay? So take a deep breath. Let it out. Let's all gather a little late afternoon energy. Okay. Now we're ready for this 48-year-old woman with chronic symptoms of sleep disruption, decrease in mental and emotional and physical energy. Another one. Another midlife woman with fatigue and brain fog and no energy. This patient has low-grade depression. Now, in America, I think we are throwing the word depression around very loosely. If someone is not happy, they're depressed. If they're depressed, they need a drug. So we give powerful drugs that actually don't help with depression very much. But they do change people's brains. She also is perimenopausal. She's having irregular periods, and the periods are getting lighter. And her last period was 2 months ago. So is she menopausal yet? We don't know. Because what's the definition of menopause? You have to go 1 full year with no periods, and then you can say, I went through menopause a year ago. And on Wednesday, I'll explain why we make you wait a year before you get to say, You went through menopause a year ago. So here she is, the perimenopausal depressed woman. So we're going to be discussing all of these common findings that cause increased estrogen in perimenopause. She can have environmental toxins that act like estrogens, the xenoestrogens that Dr. Roundtree talked to you about this morning. She could have cortisol steal that Dr. Hanaway told you could be stealing progesterone away to make cortisol. So her progesterone is low. She could have insulin resistance, which would increase testosterone, which might make her not so much irritable, but aggressive, like nasty. She could have genetic estrogen metabolism enzyme variations. Her genetics for getting rid of estrogen may be making her more unable to detoxify her estrogens. And she could have nutritional insufficiencies of the nutrients needed to do phase 1 and phase 2 detoxification. Remember, Dr. Roundtree told you there were lots of nutrients that are used in that process. So what about our patient here? Well, she's an elementary school teacher for 20 years. In the United States right now, that's a very stressful job. There is a lot of stress among teachers because of some of the changes that came down from the government, because of the poor pay scale, because of the demanding parents, because of the number of students in each classroom. It's a very hard job. She's lived in the same house. There's no remodeling going on. She's married, has a husband and 2 dogs. She has 2 grown children and they live in the area. That's probably good. Might not be, but it's probably good. She has some stress from low libido. She is not that interested in having sex. But generally, her relationship with her husband is good. And she reports a good support network. You'll remember that Dr. Hyman told us how important a support network is. You remember the big church group that all lost weight together because they made it a project for the whole church? If you've got a group of people that are supporting you, you can stay afloat. You can stay happy much longer. So what about her history of depression? Well, it started after her first baby was born. So she had, after her second baby was born. She had postpartum depression at the age of 27, and she recalls that she had difficulty making decisions and that she was tearful and that she lacked energy. Now, I think of all those things as pretty normal for a new mother, particularly after you have the second child, which is when you learn that 2 children is about 4 more than 1 child in terms of the amount of work, the amount of stress, the lack of sleep, and all of those things that go into new motherhood. Plus, the postpartum period is often when you uncover nutritional insufficiencies. During pregnancy and during breastfeeding, all of the good stuff, the good nutrients, go to the baby, right? The baby is preferentially given things like omega-3 fatty acids to make the brain with. And so the mother can get deficient very easily during a pregnancy. So she was treated with Pamelor, which is nortriptyline, which is an older antidepressant, which made her gain weight and made her feel foggy, and so they changed her to another antidepressant, which is Zoloft or sertraline. This is an SSRI, a selective serotonin reuptake inhibitor. On Zoloft, she felt numb, and she continued to have decreased libido. Well, actually, Zoloft probably caused decreased libido. However, overall, she thought it helped, so she stayed on it. Does that look like it helped? She's gone through 2 drugs. She felt numb. She felt foggy. She's gained weight. And she goes to the doctor and says, I think it's helping. There is something in psychiatric drugs called intoxication anagnosia. Do you know what that is? Intoxication anagnosia. That is where the drug itself makes you unaware of how you're doing. Have you ever been out with a group of people who were drinking alcohol and you're not? And suddenly you look around and everyone else is acting really stupid. They're doing very foolish things. And they don't know it because they're drinking alcohol. Or have you ever sat down with somebody drinking coffee, with a group of people having coffee, and suddenly they're talking really fast and they're all excited and they're having coffee, and you're not. The fact that they don't know that they're talking too fast and looking silly and saying dumb things that they wouldn't normally say, the fact they don't know that is anagnosia. These drugs, the ones that we commonly use for depression and anxiety, produce intoxication anagnosia. So the family says, he's not any better. You know, she's numb, she doesn't talk anymore, she's withdrawn, she doesn't, you know, her brain's foggy, she doesn't want to have sex anymore, she's not better. But the patient comes in and says, I think things are better. Yeah, things are better. And so the doctor says, okay, well, maybe we should up the dose a little bit. This is what's going on in the United States. So, 2 years ago, she tried to make a change. She switched from Zoloft to Wellbutrin, bupropion. However, then she had a really bad reaction to that, so she was switched to Surzone, which is nefazone, and this resulted in improved thinking and less foggy headedness, but she still had low energy and low libido. And then she was switched one more time to Vistaril, hydroxyzine, but she felt hungover, so she switched back to Surzone. I can't tell you how often I see this story. Each one of these drugs changed the production of neurotransmitters, changed the receptors for her neurotransmitters in ways that we have no understanding of. These drugs can actually change the anatomy of her brain. If you look at the brain on MRIs in people who've been on these drugs, they will have anatomic changes of their brain. And we have no idea what to expect when we put them on these drugs. Now, another one of her problems was non-cyclical acne rosacea. So it's not acne, it's not cycling with her menstrual period, it's constant. And they put her on metronidazole, which is an antibiotic, antiparasitic cream, and she's been on it for 8 years. So what would we do for acne rosacea? What's the thing you would be thinking about if you saw somebody with acne rosacea? Can you remember from Dr. Hanaway's talk on the gastrointestinal tract? Maybe hydrochloric acid, right? So we're going to be thinking functional medicine. We're not going to be thinking rosacea, drug. We're going to be thinking, we're going to be thinking acne rosacea, gastrointestinal tract, poor hydrochloric acid production, Maybe we should look at the GI tract. So maybe what this patient needs is a 4R program, a 5R program. We added an R somewhere back in the last few years, so those of us who've been in functional medicine for a while sometimes forget the last R. So her past medical history, she's got dry skin, cold hands and feet. These are significantly more pronounced in the last 2 years. And at age 35, she was diagnosed as hypothyroid because of an elevated TSH. She was put on 0.1 milligrams of Synthroid, that's T4, or levothyroxine, but she didn't feel any different. Now, for me, that's a red flag. Do you have that phrase, a red flag? It means a warning.